I'm Steve Harrel, Professor at Texas A&M College of Dentistry, Graduate Periodontics Department. I'm going to talk about controlling aerosols from ultrasonic scalers in the area of COVID-19. As a disclosure, I do hold several patents related to ultrasonic scalers. Let's start out with talking about the basis of infection control, controlling the spread of infection at its source. Don't let it get out in the environment. And historically, cholera, you purify the water source. Surgical infections, you use sterile technique. Hospital infections, isolate the patient. And anthrax and cattle, you eliminate the infected animals. In other words, you eliminate the source of the infection. You don't try and stop it once it's out. In dentistry, that means don't let the contaminated material exit the mouth and enter the treatment room environment. And that also means don't depend on secondary engineering controls or after-the-fact devices. That would be HEPA filters, upstairs UV lights, room fogging, positive pressure ventilation, and outside-the-mouth suction devices. So the other question we need to look at is, what is the source of contamination during ultrasonic scaling? And there's a very simple answer to that. The patient is the source of contamination. Now, what that means is if you take an ultrasonic scaler and you hold it up and turn it on and there's this great cloud of mist and splatter, that is not the source of infection if you have maintained your dental unit water lines, which has been recommended and mandated by CDC and ADA for over 15 years. If you do that, this is not going to be a source of contamination. This should be very clean water. The source of contamination is your patient. And specifically, this would be patients who are asymptomatic. They may carry the COVID virus, but they have no symptoms, or they're pre-symptomatic, or they're in the convalescent phase. But when you use an ultrasonic scaler on patients with COVID, you are going to get contamination of the spray. So there are no studies that look at how much virus goes into the spray or in any other situation. There are a few that look at bacterial spread. This is a study which I published looking at blood in the aerosols. And essentially what we did is we used an ultrasonic scaler to perform scaling and root planing, and then we placed a high volume evacuator about 3 to 5 centimeters away from the tip. We never touched the patient or touched the floor of the mouth. And then we used a test for occult blood to see if there was blood in the aerosols. What we found is 100% of the time there was blood in the aerosols. So what was happening is the ultrasonic scaler touches the patient, and when it touches the patient, the aerosols become contaminated. So what do we do about it? I recommend a 3-step procedure, and this was published in Dimensions of Dental Hygiene in August of 2020. And it's a 3-step procedure. 1, reduce the number of viral particles in the mouth with antiseptic rinses. 2, reduce the amount of aerosols containing viral particles that escape the mouth. And 3, use adequate protective equipment to protect you from the small amount of viral particles that may remain. So let's go through each of these steps. Number 1, antiseptic rinses. What antiseptic rinse do you need to use? Well, it seems to change every week. But at this point, I would recommend using hydrogen peroxide, diluted hydrogen peroxide rinses. I have tried the diluted bleach solution, the diluted povidone iodine solution. My patients hated the taste. The hydrogen peroxide seems to be the most current. I would recommend it, but you need to watch that closely because it does seem to be changing frequently. So I do think with the rinses, it's very important to have a multi-step rinsing schedule. And by that, I mean that when the patient first walks in the room, have them rinse for 30 to 60 seconds with the antiseptic mouthwash, and then seat them in the chair and talk to them about medical history, talk to them about their grandchildren and their pets, whatever you need to do. And then right before you start treatment, have them rinse again. So what these 2 rinses do, the first rinse will really knock down the number of viral particles. We do have, again, a study on bacteria. It will knock down bacteria in the mouth and in the aerosols by 40 to 80%. but they immediately start to reinfect from saliva and the nasopharyngeal area. And so we have them rinse again before you actually start treatment. That's going to greatly reduce the viral load. If you have a long procedure, I recommend that during the procedure, have them rinse again. And I do recommend having them rinse when the treatment is completed. Now, what this will do is reduce the viral load. It will not eliminate the viral load, which brings us to step number 2. Control the aerosols in the mouth. Don't let the contaminated aerosols get out of the mouth. How do we do that? It's actually pretty straightforward. The proper, underline proper use of high volume evacuation will remove contaminations in the mouth and limit the contamination released into the treatment room by greater than 90%. My particular research showed 93%. There's several studies out there showing slightly below that or slightly above it. And a few of those are on this slide. So what is the proper use of a high volume evacuator? You have to keep it within 2 centimeters of the ultrasonic tip. That means you can't put it in front of the mouth, you can't put it to one side of the mouth, you have to have it following the ultrasonic tip. And there's only 2 ways I know of to do this. The first is standard four-handed dentistry, 2 people, a trained assistant and the operator. The assistant must be trained, they must follow the ultrasonic scaler all the way around the mouth, staying 2 centimeters away from the tip. The other way is a high volume evacuator that is attached to the ultrasonic, which means that it always follows the ultrasonic scalar tip and stays the proper distance away. Next question, is a saliva ejector a high volume evacuator? The answer is unequivocally no. It is too small. It will get a little bit, as you can see in this photograph, but it will leave most of the aerosols behind and contamination will get out in the room. So a high volume evacuator, usually these are 10 millimeters in diameter, held 2 centimeters away from the ultrasonic tip. This is going to get most of the aerosol, as you can see in this photograph. And here is an ultrasonic scaler going without any suction, and you see the large cloud of particles. And then the same ultrasonic scaler, same water level, same power level, with a standard high volume evacuator 2 centimeters from the tip, you can see it's getting most of the aerosols. The other option is a high volume evacuator attached to the ultrasonic. This is a patented device, so there's only one of them out there. It's the safety suction by Quality Aspirators. Be aware of the fact that I do hold the initial patent on this, so I'm definitely biased, but this works really well. They have redesigned it. It is ergonometric now, and it does hold the suction tip right at the correct 2 centimeter distance from the ultrasonic tip. And here you have the ultrasonic going with no suction, and then the same ultrasonic with the safety suction in place. Third step, protective equipment. This is the much maligned N95 mask. I really think personally that a level 3 surgical mask would probably do about the same thing, but currently protective equipment is to use the N95 mask. So let's look at this at a graph. And this goes back to an article I published in the Journal of American Dental Association with John Molinari, and we talked about layers of protection. One protective device or approach is not enough. You need multiple layers. So on the left-hand side, the patient is going to walk in with 100% of whatever their viral load is going to be. It may be 0, it may be millions of virus, you don't know. But whatever it is, they'll walk in with 100%. The next bar shows after using rinses. Remember, rinses will drop bacterial load by 40 to 80%. So I put 40% in here. So we've dropped from the 100 to 60. Much less viral load we have to worry about. Now, against that viral load, we are going to use a high volume evacuator in the mouth, 2 centimeters away from the tip, and it's going to reduce that by 93%, which brings it down to around 4% of the viral load the patient walked in with. So we have reduced it dramatically with the first 2 layers of protection. Then we use the protective device, mask, etc., to protect us from this greatly reduced volume of aerosol. We're not working against the high volume they walked in with. We've reduced it to a very low level. So, to review, infection control with ultrasonic scalers, I recommend 3 layers. First layer is rinses. Second layer is high volume evacuator, 2 centimeters away from the ultrasonic tip. Control the aerosol in the mouth. And number 3 is adequate protective equipment to protect against the greatly reduced viral load. It is my opinion is if you follow these 3 layers, the risk of using an ultrasonic scaler will be minimal. Thank you. Here is my email if anybody is interested in sending me a question. If you're interested in the safety suction, this is their website, or you can Google safety suction or quality aspirators, and it should come up with this. Thank you.